Good evening. Welcome, Professor Firoz Qadir sirs and the members of BD Physicians and all the participants, those in the webinar or in the live, Facebook Live. Welcome you all. I give thanks. BD Physicians give me the opportunity to describe some topics like gallbladder disease ins and outs. Before we start the disease process, we discuss some anatomy and physiology to recapitulate our previous knowledge. Because without anatomy and physiological knowledge, we cannot complete our disease process treatment. So surgical anatomy of the gallbladder started first. It is a pure globular shaped organ, location right hypochondrium in inferior surface of the liver in gallbladder fossa. It have three parts: fundus, body and neck. Hartmann's pouch, it is the outpouching at junction between the neck and the cystic duct. Gallbladder drains through the cystic duct, which joins with the common hepatic duct to form the common bile duct. Valve of Hister is produced as functional valve due to contraction of gallbladder. So though this is a very basic thing, but it must be remembered all the time. Without knowing this knowledge, we cannot recapitulate and introduce our treatment process. So this is the picture shown here. The fundus body.
Slide share. Slide share ta jodi ekটু kindly করে নিতেন স্যার.
Slide share. Slide share.
আপনি প্রেজেন্টেশনটা ওপেন করে মোস্ট প্রবাবলি স্যার আপনি অফ করে দিবেন তো স্যার আপনাকে আবার একটু
এখন ঠিক আছে?
Yes sir, clear sir.
Okay. So this is the basic thing. We just recapitulate our previous knowledge. So another important anatomical knowledge is Callo's triangle. Previously, it is called the Callo's triangle. Nowadays, it is called the cystohepatic triangle or cystobiliary triangle. It is an important landmark to identify the cystic duct and cystic artery during cholecystectomy. The boundary is above the inferior surface of the liver. Below is the cystic duct. Medially, the common hepatic duct. This is the boundary. The contents of Callo's triangle: cystic artery, right hepatic artery, and cystic lymph node, which is called lymph node of Lahm. These are very important landmarks for during surgery. We identify the lymph nodes and indicate that there is a vessels below it. And nowadays, this is a very important thing, is a critical view of safety. The surgery all the time become more critical because all the time there is a danger to accident the biliary trees. For prevention of the biliary tree, nowadays the critical view of safety conception arises. That thing is, whenever we dissect the Callo's triangle, we delineately separated the peritoneal reflection, and there is only two structures in the common cystic duct and the cystic artery. No other structures. No other structures within this triangle. If any other ductal structure seen, that indicates there is a chance of common hepatic duct or right hepatic ducts enters there. For that reason, that critical view of safety, all the gallbladder picture must be taken in your mobile phone or the video recording, because whenever any issue happen after surgery, you can reproduce in the code that this is my operation time video or the picture. I do it safely. So for that reason, that critical view of safety nowadays is very important one. So this is the picture of critical view of safety. So this is the gallbladder. The peritoneal reflections anterior posteriorly dissected. The two window is made. Only two structures, cystic duct and cystic artery. So safely can do it. It can prevent the biliary tract injury. Another important landmark is Rubier's sulcus. In our student life, whenever in the 5th year or after post-graduation, that Rubier's sulcus importance at that time we don't know. But nowadays, the day is coming all the time, the safety is the fast. For that reason, that important landmark is important one. This is the Rubier's sulcus. That Rubier's sulcus indicate it is the right hepatic duct runs through this group along with the artery. And there is a horizontal line. If you do surgery above this line, you are always safe. If you do dissections below this line, there is chance of injury to the common bile duct or common hepatic duct. For that reason, the Rubier's sulcus is also take important roles. Some anatomical variation needed to know, which is called the Moynihan's caterpillar hump. In that case, the right hepatic artery can be tortuous and may lie very close to the gallbladder and the cystic duct before giving a short cystic artery, which can lead to inadvertent arterial injury or bleeding during cholecystectomy. So in a normal callous triangle, that right hepatic artery is not seen like that manner. It is carved and it appears like a caterpillar. For that reason, it is called the Moynihan's caterpillar hump. It is one of the anomalies. So the variation also no, otherwise you can injury during surgery. Surgical physiology of gallbladder. Bile is produced by the liver, stored in the gallbladder before being released into the duodenum. The liver excretes bile at approximately 40 ml per hour. As it leaves the liver, its composition is 97% water, remaining 3% consists of bile salts, cholic and chenodeoxycholic acid, deoxycholic and lithocholic acids, phospholipids, cholesterol, and bilirubin. About 95% of the bile salts are reabsorbed in the terminal ileum and returned to the liver, which is called enterohepatic circulations. Additional function of the gallbladder is the concentration of the bile by 5 to 10 times by active reabsorption of water, sodium chloride and bicarbonate via the mucous membrane. The gallbladder mucosa also secretes approximately 20 ml of mucus per day. This is also an important thing, the amount of mucus which is secreted per day in the gallbladder. I mentioned that ml because in part 1 examinations, FCPS, some of the MCQ question may arise from here. For that reason, the description I take here. If the cystic duct is completely obstructed in an otherwise healthy gallbladder, a mucocele may develop as a result of ongoing mucus secretion. So the disease is divided in the inflammatory and neoplastic. It's a very big chapter. I only describe today is the inflammatory chapters. So the gallbladder disease is called the cholecystitis. That cholecystitis again divided into 2 parts, acute and chronic cholecystitis. That acute again divided into the calculous cholecystitis or acalculous cholecystitis. Same thing happened in the chronic calculous and acalculous cholecystitis. The cholecystitis may happen without stone, which is called acalculous. Whenever a stone with infection, it is called calculous cholecystitis. Look, the picture is, whenever there is inflammations, there is the exudations, there is the fibrin depositions, which causing that type of filmy adhesions there. These are the organized and subsequently becomes adhesions happen. So see the pictures and imagine what thing happened in the abdomen is. So we now describe about the cholelithiasis, that means stone in the gallbladder. So that gallstones, the cholesterol stones, 6%, usually single, has radiating crystal-like appearance. Mixed stones, 90%, which is commonly present. Most common and usually multiple, composed of cholesterol, bile acid, and pigment, plus calcium sulfophosphate, carbonate, palmitate. Usually they are multiple and faceted. These are the characteristic points in favor of mixed stones. In case of pigment stones, 4%, they are brown or black. Brown pigment stones composed of cholesterol, calcium bilirubinate, calcium stearate, calcium palmitate. in black pigment stone composed of cholesterol, bile salt, calcium bicarbonate, and calcium phosphate. So these are the pictures. In a cholesterol is a single one. In mixed stone, these are multiple faceted, and pigment gallstones are black in color. So these are the 3D 4K images taken in my private patients. These are the various pictures of the gallstones in various appearance. So pigment stones, again divided into black pigment stones and brown pigment stones. Black pigment stones, most common, almost always found in the gallbladder. It is commonly found in hemolytic disorders and also often seen, it is common found in hemolytic disorder and also often seen in cirrhosis. Multiple, small, and hard in consistency. In brown pigment stones, rarely found in the gallbladder, formed in the bile duct is as primary biliary stones. It is very important one thing is, whenever the stones develop in the common bile duct, it is called the primary biliary stones. When the stone is migrated from the gallbladder to the biliary tree, common hepatic duct, common bile duct, it is called the secondary bile stone, biliary stone. Commonly occurs due to the bile stasis and infected bile. Infection with E. coli bacteroids causes formation of bacterial nidus at the center. Risk factors of gallstones. Age, elderly patient usually. Sex, female is the most common. Oral contraceptive therapy, they are more prone to develop gallstones. Obesity, another cause. Diabetes mellitus, after gastric surgery, inflammatory bowel disease, hemolytic anemia, total parenteral nutrition patient. These are the risk factors. The gallstones having the 5 F's. The F means fair, fatty, female, fertile. These are the factors happen in case of female. Commonly, the 5 F's are described. Pathogenesis of gallstone formation. These are the metabolic cause, infection cause, and bile stasis. In case of metabolic cause, solubility of cholesterol is determined by relative concentration of cholesterol, bile salt, and lecithin. Altered level of cholesterol, lecithin, and bile salts in bile reduces the mycelic concentrations in the bile, leading to precipitations of insoluble cholesterol, hence the stone formations, which is called lithogenic bile or supersaturated bile. Normal ratio of bile salt and lecithin to cholesterol is 25:1. Whenever the ratio is 13:1, at that case, it leads to precipitation of the cholesterol stone formations. In case of infection, the role of infection in causing gallstone is unclear. Often bile from gallstone is sterile, but organisms has been cultured from the centers of gallstones. Bacteria like E. coli, Salmonella, parasites like Chlorhynchus sinensis, Escherichia lumbricoides are often associated. Moynihan's aphorism: a gallstone is a tombstone erected to the memory of the organism within it. The bile stasis, gallbladder contractility is reduced by estrogens. So in pregnancy and after truncal vagotomy, which predispose to gallstone formations, patients on long-term parenteral nutrition have a high incidence of gallstones. Lack of good oral intake prevents the release of cholecystokinin, the hormonal stimulation of the gallbladder contraction released from duodenal mucosa. The symptoms, clinical presentations, the symptoms. Gallstone may be asymptomatic, which is termed as silent gallstones. The presentations are biliary colic or acute calculous cholecystitis, chronic calculous cholecystitis. In case of biliary colic, it is the commonest presentation is sudden onset of constant severe pain in the right hypochondrium, lasting between 20 minutes and several hours with pain, often radiating to the back or right scapula. This pain may be very intense and may be relieved by spontaneous disimpaction of the gallstone from Hartmann's pouch or migration of the stones into the common bile duct. This is a very important thing is the patient having a severe pain in the right upper abdomen and suddenly become relieved. That means it indicates, commonly happen, the impacted stone again dislodged into the gallbladder lumen. The patient is subsiding. At that time, most of the patient taken some anti-ulcerant drugs and all the patient presentations and managed by anti-ulcerant drugs. But the presentation is managed automatically by natural process. Why? During pain, when the patient is posture change, the postural change causing disinfection of the stones from the neck to the lumen of the gallbladder, and the pain is subsiding. So in case of acute calculus cholecystitis, sudden onset of intense pain in the right hypochondrium, with time as a sterile inflammation develops, the pain progresses to constant severe pain lasting for hours or days. Pain may often radiate to the back tip of the right shoulder. Fever present, nausea and vomiting present. These are the commonest presentations. In case of chronic calculus cholecystitis, the pain is the severe dull-aching pain in the right upper quadrant. Pain may be referred to the tip of the right shoulder or the back. Pain aggravated by taking fatty food, flatulent dyspepsia, no fever, no nausea, no vomiting. So in case of chronic cholecystitis, the symptoms are very minimal. Signs. On general examinations, in case of acute calculus cholecystitis, temperature raised, tachycardia. On local examination, tenderness in the right hypochondrium, the muscle guard present, muscle rigidity present, Murphy's sign positive. These are the main clinical signs by which you can differentiate the patient having a cholecystitis, acute cholecystitis present or not. This is the main point to identify the Murphy's sign is positive or not. Both sign may be positive and gallbladder may be palpable. On chronic calculus cholecystitis, on general examination, temperature normal. On local examination, no tenderness in the right hypochondrium, muscle guard absent, muscle rigidity absence, Murphy's sign negative. Gallbladder may be palpable if there is associated mucocele or empyema of the gallbladder. So there is a sense triad. It comprises of gallstone, diverticulosis of the colon, and hiatus hernia. The Murphy's sign, it is a very important clinical sign or noun sign named after Bernhard Neumann, professor of medicine, Strasbourg, who described in 13 years before John Benjamin Murphy, is elicited by asking the patient to breathe in while gently palpating the gallbladder area. That means tip of the ninth costal cartilage. At that area, whenever press and ask the patient to take deep breath, the patient will experience pain and catch her breath just before the height of inspiration. It is positive in case of acute cholecystitis. So that clinical examination is very important for all the students. In case of Bose sign, area of hyperesthesia between 9 to 11 ribs posteriorly on the right side. So investigations needed to differentiate diagnosis of acute calculus cholecystitis and chronic calculus cholecystitis. In case of acute calculus cholecystitis, the total count of the WBC is raised, liver function test to rule out jaundice, ultrasound of whole abdomen with a special attention to hepatobiliary system and pancreas confirmatory test, and plain X-ray abdomen to rule out gallstone in 10% radiopaque stones seen in case of plain X-ray abdomen. In case of porcelain gallbladder, it is seen in porcelain gallbladder in plain X-ray abdomen. Emphysematous cholecystitis gas may be seen in the gallbladder area. Perforated peptic ulcer to rule out. So these are the plain X-ray. You can differentiate the other diagnosis. And others like HIDA scan, hepatobiliary immunodiacetic acid. The HIDA agent is excreted in the biliary tree within 1 hour of isotope administrations. In acute cholecystitis, even isotope is excreted in the biliary tree, it does not enter the gallbladder due to edema of the cystic duct, blockage of the duct. So there is no visualization of the gallbladder. By that things, you can evaluate there is acute cholecystitis or not. CT scan not only detects gallstone, but also detects perforation used when the ultrasound findings are not clear. At that time, you can do the CT scan. It's very informative to look and evaluate carefully. In case of chronic cholecystitis, complete blood count is normal. Liver function is very normal to rule out jaundice. Ultrasound of the whole abdomen with special attention to hepatobiliary system and pancreas to confirm the test. And plain X-ray abdomen, there is 10% gallstone and porcelain gallbladder. Other, like CT scan, not only detects gallstone, but also detects the wall thickness used when ultrasound findings are not clear. So this is the ultrasound pictures in a normal ultrasound of the gallbladder. So look, the wall of the gallbladder is there. The gallbladder is well distended. If the patient is fasting, at that time the gallbladder is distended, the lumen is clear. So this is the normal gallbladder. So in case of gallstone, the ultrasonography findings of acute calculus cholecystitis. First thing is, what about the content? Is there single or multiple? Single or multiple echogenic structure or structures casting posterior acoustic shadow, this shadow. So every physicians or doctors or medical students must read the report and also know how the picture of the calculus cholecystitis or gallstone picture in ultrasonography. Everybody must know. So if you know, you can easily look and evaluate the findings. The report is correct or not. You can easily understand. So this is a very simple things. There is a gallbladder lumen, and there is a multiple echogenic structures, and all the structures having a posterior shadow there. This shadow indicates it is a stone. And the gallbladder distension, distended gallbladder here, and wall thickness. The wall thickness can measured easily by ultrasonography. And if the patient having a pericystic collection, like, look, there is a black shadow outside the gallbladder wall. That black shadow is indicate there is a pericholecystic collections in the gallbladder bed. That indicates there is exudations, inflammations, exudations. That exudate fluid is accommodated in the liver bed. That can be detected by ultrasonography, and the diagnosis is 100% confirmed that the patient having a acute calculus cholecystitis. So that ultrasonography is very important, takes part. What about the chronic calculus cholecystitis? Whenever a patient having a chronic calculus cholecystitis, the repeated attack of infection, inflammation causing fibrosis of the wall, gallbladder become contracted, so lumen may be obliterated. So look at the picture is, the whole gallbladder area is occupied by stones, and there is acoustic shadow, black shadows there. The gallbladder is not distended. So by looking at the pictures, we can easily differentiate that the patient having a gallstone with a chronic calculus cholecystitis. So look, the gallbladder is contracted, wall is thickened, pericholecystic collection is absent. So by the two pictures, we can easily evaluate what condition of the status is the acute calculus cholecystitis or a chronic calculus cholecystitis is. And another important thing is to know all the students and doctors how we can differentiate a gallbladder sludge from a gallstones. It is very simple to investigate the patient and evaluate the patient. Whenever the patient having show the previous picture one, there is a echogenic structures, but there is a shadow. Whenever the patient having no shadow, only the echogenic structures, and change the posture. If the change the posture, the structure changes position, it indicates it is gallbladder sludge. It is gallbladder sludge. Whenever no shadow, only echogenic structure, and change with posture of the patient, the structure migrated and other parts, it indicates it is gallbladder sludge. But sometimes we are confused about echogenic structure there, no shadow, but the position is fixed. That indicates it is a gallbladder polyp. So very important thing it is, how can you diagnose a gallbladder polyp? By doing ultrasonography? The answer is, there is echogenic structure, it does not change on posture change of the gallbladder. So these are the differentiating point by doing a simple ultrasonography and evaluate the patient. Next thing is, you do a plain X-ray abdomen. Usually we don't do it, but whenever you're confused about some other reasons, no specific clue there, at that time we can do some X-ray, plain X-ray abdomen. That plain X-ray can differentiate a lot of diagnosis. You look, there are radiopaque shadows there. So series of stones there. And by looking at the pictures, we can evaluate that. You can thinking that this is a gallstone or it is a ureteric stone or renal stones. And whenever you're confused about the gallstone or renal stone, then you do a lateral view X-ray If the radiopaque shadow in front of the vertebra, it is gallstone. It is behind over the vertebra, it is the renal stone. So by that things we can differentiate what type of radiopaque shadow is. But whenever you look that pictures is, there is axial appearance there. Only the wall is calcified and shape is globular. That indicates it is the porcelain gallbladder. That means the gallbladder wall become calcified. It is a precancerous condition. So there is no stones inside the lumen, but the wall become calcified. By doing an X-ray, we can evaluate that the patient having porcelain gallbladder. And the best investigation is CT scan. If you do the CT scan, you can very clearly delineate the structures and identify it. But in case of emphysematous gallbladder, you look, that patient having a lot of gases in the abdomen there, but here the globular gas shadow is there. Whenever the gas shadow takes the shape of the organ, that it represents this organ. So in case of emphysematous gallbladder means the patient having a air within the gallbladder. So that gallbladder is well delineated here. Whenever that type of picture present, you suspected that the patient may having emphysematous gallbladder. And do the CT scan, then you can differentiate and confirm it. Is it a emphysematous gallbladder or not? And the difference between a pneumoperitoneum and the emphysematous gallbladder, by compare the two pictures, look, this is the X-ray chest PA view. There is a diaphragm sitting there, but that there is a crescentic gas shadow, which is formed by the underside of the diaphragm, the right dome, and the superior lobe of the liver. It is shapes taken in the crescentic gas shadow. But here, there is no crescentic gas shadow. For that reasons, that picture is not a free gas. It is a gas within a lumen of the organ. That means gallbladder. So by looking at the pictures, we can differentiate what finding is. Is it a pneumoperitoneum due to perforation of the duodenum, or it is a emphysematous gallbladder? By looking at the pictures, you can guess. Then you further investigation confirm it, what the lesion is. The radar scan. Nowadays, these tests are not usually done routinely. Previously, whenever the ultrasonography is not available, at that time, these are the very important investigations to takes place. So compare the two pictures. There is a normal radar scan. That means the tracer is visualized the gallbladder. The gallbladder lumen contains that radioisotope. HIDA materials is there. And this is the common bile duct. But here, the gallbladder is not visualized. The common bile duct is visualized. So that means it is a acute calculus finding. That means there is a block of the cystic duct it represents. The other clinical findings correlate and diagnose. Previously, it is a acute calculus cholecystitis. So the gallstone is a very common thing, but it having a asymptomatic patient, there is no problem. But at any time, the gallstone may produce symptoms and it may produce some complications. For that reason, it needs to treatment. Asymptomatic gallstones also need to surgical treatment to prevent that type of complication, which I described now. The common complications of the gallstones are divided in like that in the gallbladder, in the common bile duct, in the pancreas, in the intestine. So whenever the stone in the infection in the gallbladder, it causing the infection in the gallbladder is called acute cholecystitis, chronic cholecystitis. Whenever there is infection and sparse formation in the gallbladder within the lumen, it is called empyema of the gallbladder. Sometimes the gallbladder becomes necrosed and perforated. Sometimes the neck of the gallbladder is obstructed by a gallstones or the growth, whatever is the cause. The luminal content of the gallbladder become absorbed by mucous membrane, but there is a continuous secretion of the mucus. That mucus is accumulated there, and gradual distension, thinning of the gallbladder, and converted into a mucosal of the gallbladder. And sometimes that stone may predispose to develop carcinoma of the gallbladder. There is the rarest possibility also. Whenever the stone is slipped through the cystic duct, go to the common bile duct, it causing obstruction of the lumen of the common bile duct. So the patient developed obstructive jaundice. Or there is a stasis, so there is a flow is impaired of the common bile duct. So there is a cholangitis. That cholangitis is the fever, rigor, and jaundice representations that represent that the patient having cholangitis. And sometimes the stone which is present in the gallbladder, it is obstructed at the neck of the gallbladder. And whenever the stone is obstructed at the neck, that is make a pressure effect near the surrounding structures like common hepatic or the duodenum or the antrum of the stomach, which causing inflammations. Where there is inflammations, there is a adhesion by inflammatory exudates to the surrounding structures. And that adhesion ultimately pressure effect and causing a fistulous formations. And that fistulous formations causing migration of the stones to the common hepatic duct or the intestine and causing the syndrome which is called the Meninges syndrome. It is a very favorite term, Meninges syndrome. So everybody must know it, particularly in the surgical peoples. Whenever the stone passes through the ampulla bladder, the ampulla is distorted, and there is a chance of development of the pancreatitis, which is called gallstone pancreatitis. And whenever the stone is migrated to the intestine and passing to the intestine and passes distally, ultimately, whenever the stone is the big size, more than 2.5 centimeter, the stone is stuck at the ileum, near 2 feet proximal to the ileocecal junctions, where is the narrowest part of the intestine, and the patient presented with a intestinal obstructions. So for that reason, that thing you must know, that are the complications may happen whenever a patient having a gallstones. So treatment. In case of acute calculus cholecystitis, the treatment is always treat the patient nothing per oral, nasogastric suctions, IV fluid, broad spectrum antibiotics, analgesics, and observations. And what is the status of the patient is? Either when the temperature, pulse, and other physical signs show that the inflammation is subsiding, usually by the third day, the nasogastric tube is removed, fluid followed by a fat-free diet are given. Cholecystectomy by open and laparoscopy method is performed during the same admissions 2 to 3 days after the acute episode has resolved. After the acute is resolved, then conservative treatment must be abandoned if the pain, tenderness spreads across the abdomen and pulse rate rises. That indicates there is a gangrenous gallbladder. So a percutaneous cholecystostomy is performed by radiologist under ultrasonic control, will rapidly relieve the symptoms. Subsequently, cholecystectomy will be required. So these are the treatment protocols for acute calculus cholecystitis. But the setup is good setup and advanced instrument present. If the patient is fit for surgery, you can do surgery earliest is the best. Because in case of acute cholecystitis, the exudate are there the filmy adhesions, easily separated from the bed. But the difficulty is the edematous gallbladder is maintained is very difficult. Handling is very difficult. So look at the few seconds in acute calculus cholecystitis. Finished by being in the same setting, go for calculus cholecystitis. So look, there is the exudation of the bile from the gallbladder open to the village bile is there. So the gallbladder is filled up with pus and bile. Straight go the sucker and suck it out. So reduce the contents and easily can handle the gallbladder. But if it is distended, it's very difficult. That thing is possible because the advanced image systems and the ultrasonic diathermy is available for that. So in case of acute calculus cholecystitis, why emergency cholecystectomy is not done usually in acute cholecystitis? These are the normal terminology used in case of asked in the exam. Because my thinking is these are the previous conceptions. The new conceptions are, if you expert enough, you can do it. So for the exam, that thing you must remember. Because extensive adhesions makes difficult dissections, difficulties in identification of the structures, excessive bleedings, inadvertent injury to the bile duct, hepatic artery, or portal vein. But it can be performed if the surgeon is experienced enough and excellent operating facilities are available. In case of chronic calculus cholecystitis, the operation is cholecystectomy, provided that the patient is fit. either open or laparoscopic one. Laparoscopic cholecystectomy is the gold standard treatment of cholecystitis nowadays. So, in case of open cholecystectomy, the anesthesia is general anesthesia. Incision is Coker's incisions or right subcostal or midline incisions, whatever the choice of the surgeons. Then they'll need the structure, identify it, hold it, neck it, ligate it, cystic artery is divided, then you remove the gallbladder. So these are the open methods. The laparoscopy methods also needed to general anesthesia, and abdomen needs to insufflate with the carbon dioxide gas. And 4 ports are made: 10 millimeter umbilical port, 5 millimeter midline epigastric port, working channel for surgeons, 5 millimeter right subcostal port, and 5 millimeter right iliac fossa port. Some bodies, whenever the 5 millimeter camera is not available, they do it with the 10 millimeter in the midline port. So it depends upon what facility is available. According to this, you can make the port. So the surgery is done only the few small incision. So this is an acute calculus. In the normal calculus look at the picture. Gallbladder right and peritoneal reflections, take part. So the neck is far away from the colostrum. Easily identify. Diathermy is good. Diathermy is good. So identify the critical view of safety. One window is down and another window is open. So there is 2 window made. So nothing is there. What is there? It is back down. So this is the critical view of safety. There is a main sound for the right hepatic artery, right hepatic artery, right hepatic artery. So that cystic artery is divided into the fundamental diathermy. Then you do the flip. So the peritoneal reflection the gallbladder is separated from the gallbladder bed. There is a cholecystic hepatic plate there, abstracted and divided. And after that, gallbladder is fixed. Duct is skeletonized more, so there is no stuff in between and the hepatic part. Right? There's no need of weight. Right? So clean. The common content is shown there. There is a anaphylaxy where artery is in front. Usually the artery connected or contact. So this is about cholecystectomy, laparoscopic method. The advantage of laparoscopic method is less postoperative pain, reduction in bleeding, wound infections, herniations, and nerve entrapment, improved vision, better cosmesis, improved mobility, shorter hospital stay, earlier return to normal life, earlier resumption of normal activities. So good setup can more clearly visualize, and doing surgery, there is 3D image facilities which is available in my private chamber. So another important thing nowadays, there is a demanding issues, that is ICG dye administrations before doing cholecystectomy. That means the dye is injected 25 minutes to 30 minutes before doing cholecystectomy, which is excreted through passes through the circulations, go to the liver, then it passes through the biliary tree, and whenever the ICG, that means fluorescent light switch on, the light source, then the liver become greenish, the gallbladder become greenish, and the common bile duct also greenish. It prevents biliary tree injury. So that can also available in our private chamber setup. So ICG is nowadays another standard techniques to for safety of the cholecystectomy. So cholecystectomy complications. It is very important thing, because once complication develops, it helps the life of the patient. Injury to the CBD, common bile hepatic duct, duodenum, right hepatic artery. Hemorrhage if slippage of the cystic artery ligation. Accidental ligation of the CBD, Accidental ligation of CBD leading to the bile duct strictures, which causes obstructive jaundice. Retained stone in CBD or migration of stone in the CBD, residual abscess, biliary peritonitis due to slippage of cystic duct ligature or injury to the bile duct. Bile causes irritation in the peritoneum. Due to collection in the right subhepatic space leads to Waltman-Walter syndrome. This is a very important topic's name is Waltman-Walter syndromes. That patient present to you like a MI-like syndrome, MI-like chest pain, because whenever there is a collection in the subhepatic space and subdiaphragmatic space on the right side, the liver is pushed downwards. The downwards causing angulation of the inferior vena cava. Whenever the angulation of the inferior vena cava, there is a less blood supply to the venous output to the heart, input of the heart, which causing less supply to the coronary supply, and the patient pain to like a chest pain. For that reason, which is called Waltman-Walter syndrome. Acute cholecystitis, acute and chronic. The acute and chronic calculous cholecystitis can occur in absence of stones, give rise to clinical features similar to calculous cholecystitis. Precipitating factors for development of calculous cholecystitis: critically ill patients, major surgery, trauma, burn patient, immunocompromised patient, dialysis patient, typhoid fever patient, and diabetic patient. These are the predisposing factors in case of calculous cholecystitis. Calculous cholecystitis, which is called cholecystosis. These are the group of conditions affecting the gallbladder in which there are chronic inflammatory changes with hyperplasia of all the tissue elements. Cholesterosis and strawberry gallbladder. The interior of the gallbladder looks like strawberry. There is yellow areas of submucosal cholesterol deposition. Cholesterol polyposis, that means cholesterol-laden polypoid projections in the mucosa. Cholecystitis glandularis proliferans, that means granulomatous thickening and hyperplasia of the gallbladder, and diverticulosis of the gallbladder. These are the called cholecystosis, strawberry gallbladder. What about the mucosal of the gallbladder? That is very transparent. Whenever you pass the light, it can easily pass from one side to the other side. So the pathogenesis of the mucosal is asked in the exam. That is obstruction of the cystic duct due to stone or neoplasm, failure of drainage of the bile through the cystic duct, absorption of water and water-soluble contents of the bile, and hypersecretion of mucus, excessive accumulation of mucus within the gallbladder, which causing distension of the gallbladder and represented as a mucosal of the gallbladder. That mucosal clinical features are painless swelling in the right hypochondrium, Non-tender, smooth, soft, globular, palpable gallbladder. Content is sterile. Features of dyspepsia. Complications. If infected, can cause empyema gallbladder. Rupture can cause pseudomyxoma peritoni. Very rare. Treatment is cholecystectomy. So this is the empyema of the gallbladder. Whenever you divide it, the pus came out from the gallbladder. So empyema gallbladder, it is a type of acute cholecystitis wherein the gallbladder is filled with pus. It also can occur in a pre-existing mucosal of the gallbladder where it gets infected. It can perforate and can cause peritonitis. Clinical features: high fever with chill and rigor, swinging fever, toxicity, pain and tenderness in the right hypochondrium. Tender, smooth, globular gallbladder is palpable in right hypochondrium. Investigation: doing ultrasonography, total blood count is raised. That empyema gallbladder treatment: complete bed rest, nothing but mouth, nasogastric suctions hourly, IV fluid and electrolytes, broad-spectrum antibiotics, cefotaxime, quinolones, ceftriaxone, anyone, analgesics, cholecystectomy, emergency procedures. Sometimes cholecystostomy is done with either Foley catheter or Melliker's catheter in situ. Later, after 3 to 6 weeks, cholecystectomy is done. Complications: if untreated, septicemia, perforation, and peritonitis. So another thing is, this is called the gallstone ileus. That means the gallbladder is adhesion with the duodenum, and due to the inflammations, so adhesions, subsequently the stone is eroded the muscle coat of the gallbladder, mucosa muscle, then the intestinal duodenal mucosa muscle and the mucosa, and ultimately the stone is dislodged in the lumen of the duodenum. Then it passes forwards. It is a type of acute intestinal obstructions often seen in elderly and is due to blockage by a bolus or pus of gallstones which commonly enter the intestine through cholecystoduodenal fistula, 75% of cases. The pathogenesis of gallstone ileus is gallstone in the gallbladder, stone size more than 2.5 centimeter. There is cholecystitis, suppurations and adhesions over the duodenal wall, communication of the gallbladder into the duodenum. Gallstone passes into the duodenum, forms a bolus, rolling stone together mass, blocks narrow part of the ileum, gallstone ileus develop. So clinical presence features are pain in the abdomen, features of intestinal obstructions. Stones may perforate in the ileum to cause peritonitis. Recurrent episodic obstructions due to moving stones, bolus is typical tumbling obstructions. Investigations: plain X abdomen in erect posture shows air in the biliary tree, which is called the pneumobilia, and multiple air fluid level in the intestinal obstruction. An ultrasound of the abdomen can detect the air in the biliary tree, and CT scan is a diagnostic. So look at the picture. This is one of my private patients, diagnosed before operations. That patient present to me like that way. Then I do a CT scans, and after doing CT scan, it can easily identify it. Look at there. There is a gallbladder stone there, and there is some gas shadows. And look at this picture. Intestine, there is a stone. So that is stone causing intestinal obstructions. So the report is cholelithiasis with cholecystitis, cholecystoenteric fistula, dense structure within the ileum, mildly distended small bowel lobes with intraperitoneal collections. So their CT scan can easily delineate the gallstone ileus disease. So treatment is little bit different than gallstone other treatments. The laparotomy, enterotomy, removal of the gallstones, and closure of the enterotomy is done. Enterotomy is done not at the site of obstruction, but more proximal to the site of obstruction, and stones are milked towards the enterotomy sites. If bowel is found ischemic at the impacted area, resection anastomosis may be done. Laparotomy and crushing of stones with fingers to relieve the obstruction is only occasionally useful. Cholecystectomy, correction of fistula, can be done in same sitting if patient's general condition is good. Otherwise, it is done after 12 weeks. If cholecystectomy and definitive corrective surgery is not done, recurrent gallstone ileus is likely to occur. So, important topics is Medigis syndromes. Look at the pictures. There is a stone impacted at the neck, which causing adhesion to the common hepatic ducts. And whenever the duct stone is eroded, then it goes down and causing when the stone eroded and go down and ultimately go into the common hepatic duct. Or the another one is make perforate with the intestine. So gallbladder impacted in the Hartmann's pouch or neck of the gallbladder causes chronic inflammations and fibrosis, resulting in obstruction or erosion of the common bile duct. Type 1, compression of the common bile duct without the lumen narrowing, just adhesions and compressions. Type 2, cholecystoduodenal fistula involving less than 1/3 of the circumference of the CBD. Type 3, cholecystocoledocal fistula involving 2/3 of the circumference of the CBD. Type 4, cholecystocoledocal fistula involving whole circumference of the CBD, causing complete obstructions. And type 5, cholecystoenteric fistula, which with any other type of Meninges syndrome. Type 5A, cholecystoenteric fistula without gallstone ileus. Type 5B, cholecystoenteric fistula with gallstone ileus. These are the things written in the Indian books, not the other books I found. And Meninges syndrome is suspected on CT scan, but usually identified on table. It needs cholecystectomy, on table cholangiogram, and exploration of the CBD. It often needs Roux and Y cholecystectomy. So these are about the inflammatory disease of the gallbladder. The malignancy is another term, another big chapter we don't describe today. So up to that descriptions, I can finish my presentations. And I have one request to look and observe my, that means www.drshaiekazizchowdhury.com. I have a web page. If you have any time, please visit this website. And thank you, everybody. Thank you for patience hearing.
ধন্যবাদ সম্মানিত শিক্ষক অধ্যাপক শায়েক আজিজ চৌধুরী স্যারকে। স্যার খুব কম সময়ের মধ্যে অত্যন্ত গুছিয়ে গল ব্লাডারের বিশেষ করে গল স্টোন রিলেটেড যে কতগুলো টপিকস হতে পারে, গল স্টোন ডিজিজ ইটসেলফ এবং গল স্টোন ডিজিজের কমপ্লিকেশন, সেগুলো স্যার আলোচনা করলেন। তো স্যারকে অনেক ধন্যবাদ। তো আমি একটু প্রফেসর ফিরোজ কাদের স্যারেরও দৃষ্টি আকর্ষণ করছি যে স্যার আসলে এখন কোশ্চেন আনসার সেশন, অনেকগুলি ইন্টারেস্টিং কোশ্চেন আমাদের চ্যাট বক্সে।
প্রফেসর শায়েক আজিজ স্যার, আপনি স্ক্রিনটা যদি একটু অফ করে দিতেন।
আচ্ছা,
স্লাইড শোটা প্লিজ একটু অফ করে দেন স্যার।
আচ্ছা,
হানিবা তুমি অফ করতে পারবে না স্লাইড শো? ওকে স্যার,
ওকে।
তো আসলে একটি অত্যন্ত প্রাণবন্ত সেশন হলো স্যার। তো অনেক কোশ্চেন আসলে আমাদের এখন আমরা দেখতে পাচ্ছি যে আমাদের সাথে জুমে কানেক্টেড আছেন রাত 11টায় প্রায় 105 জন, নিশ্চয়ই ফেসবুক লাইভে আরো অনেকে কানেক্টেড আছেন। অনেকগুলো কোশ্চেন আসলে চ্যাট বক্সে জমা হয়েছে, যেগুলো আসলে সবগুলোর জবাব হয়তো স্যারদের পক্ষে আমাদের টাইম কনস্ট্রেন্টের জন্য দেওয়া সম্ভব নয়। তো আমি আসলে স্যারদের অনুমতি পেলে, প্রফেসর ফিরোজ কাদের স্যার এবং প্রফেসর শায়েক আজিজ চৌধুরী স্যার অনুমতি পেলে আমি কিছু বাছাই করা কোশ্চেন অডিয়েন্সের পক্ষ থেকে আমি তাদের নাম সহ বলতে পারি। আর যদি অডিয়েন্সের কোনো সরাসরি কোশ্চেন থাকে, তারাও স্যার আমাদের সম্মানিত স্পিকার শায়েক আজিজ চৌধুরী স্যার এবং আমাদের সম্মানিত চেয়ারপারসন ফিরোজ কাদের স্যারকে আপনারা করতে পারেন। তো সেটা যদি করতে চান আপনারা সরাসরি করতে পারেন স্যারদেরকে, আর যদি আপনারা না করে থাকেন তাহলে আমি সরাসরি আমাদের চ্যাট বক্সে কোশ্চেন আনসার প্যানেলে যে কোশ্চেন গুলি জমা হয়েছে তার মধ্যে থেকে যেগুলি সবচেয়ে অনেকগুলো কোশ্চেন আছে, খুব কমন অনেকেরই প্রশ্ন, সেগুলিতে আমরা চলে যেতে পারি। তো একটা কোশ্চেন স্যার এসেছে, খুব ইন্টারেস্টিং কোশ্চেন, এটা আমার কাছে মনে হয়েছে যে একটা পেশেন্ট, এটা কোশ্চেনটা করেছেন ডক্টর আনজুমানারা। উনি বলেছেন, ইন কেস অফ ইম্পাইমা gallbladder with jaundice due to cholecystolithiasis, if I want to do laparoscopy with ERCP and there is no scope to do both in the same sitting, then what should I do first, ERCP or laparoscopy as impaioma gallbladder? স্যার প্রশ্নটা হচ্ছে যে ইম্পাইমা gallbladderও আছে প্লাস cholecystolithiasisও আছে, সেক্ষেত্রে আমরা কোনটা আগে করব? আমরা কি ইম্পাইমা gallbladder সার্জারিটা আগে করব, নাকি স্যার যেটা আমরা নরমালি করি যে cholecystolithiasis হলে আগে ERCP করে স্টোনটা রিমুভ করে ফলোড বাই ল্যাপারোস্কোপিক cholecystectomy করব? কিন্তু ইম্পাইমার ক্ষেত্রে সেক্ষেত্রে কি হবে, ইম্পাইমা gallbladder উইথ cholecystolithiasis?
আমার this is my personal opinion is, whenever a patient having a empyema gallbladder, better to do a cholecystostomy first, so the pus escape out, then the emergency is overcome, then after subsiding the infection, and then you go for the ERCP and complete after a few weeks. Then go for the cholecystectomy. ফিরোজ কাদের স্যারের ওপিনিয়নটা কি বলতে পারেন?
আমি শায়েক আজিজের সাথে একমত। When the source of infection is there together with the obstructive jaundice, দুটোই কিন্তু is a crucial situation. কিন্তু since removal of pus is not a very difficult task in this situation, so as soon as possible আমাদের empyemaটাকে deal করে earliest possible time এ যখন patient becomes relatively fit, I won't say the patient becomes completely fit, relatively fit হয়ে গেলেই আমরা we relieve the biliary obstruction by ERCP, and then a cholecystectomy can be done. So what Shaiek Aziz has said, I think I also agree with the same opinion.
And there is another option present. If the stone is a big size in the CBD, in that cases, after subsiding the empyema drains, then go for the laparoscopic cholecystectomy with choledocholiectomy. If a big stone in the common bile duct is the alternative options. If a small stones, multiple stones, in that cases where the facility is available, go for the ERCP.
থ্যাংক ইউ স্যার। স্যার আমাদের সাথে একজন গ্যাস্ট্রোএন্টারোলজিস্ট সংযুক্ত আছেন, ওনার নাম ডক্টর সৈয়দা নূরে জান্নাত। ওনার একটা ওপিনিয়ন আছে স্যার, যদি একটু কাইন্ডলি ওনার ওপিনিয়নটা শোনা যায়।
আসসালামু আলাইকুম স্যার। স্যার আমার একটা কোশ্চেন ছিল, কোশ্চেনটা হলো যে যদি এখানে সিবিডি তে স্টোন থাকে, কোলিডোকোলিথিয়াসিস আছে, সাথে এম্পাইমা গলব্লাডার আছে, আমি যদি ইআরসিপি আগে না করি তাহলে তো এখানে পরবর্তীতে অবস্ট্রাকটিভ জন্ডিস যদি ডেভেলপ করে সেটা একটা সমস্যা হবে। এক, দুই নাম্বার হচ্ছে যদি সবসময় ইআরসিপি করে স্টোন এক্সট্রাকশন করা পসিবল হয় না, সেক্ষেত্রে আবার ওপেন করতে হয়। তো সেক্ষেত্রে তো পেশেন্টের রিপিট মানে অপারেশন দাগ লাগছে একটা। এ কারণে আগে ইআরসিপি করে স্টোন এক্সট্রাক্ট করে পরে যদি কোলিসিস্টেক্টমি আমরা করি, সেটা স্যার সে ব্যাপারে আপনার ওপিনিয়নটা কি স্যার?
না, আগে প্রথমে যদি আমার আল্ট্রাসাউন্ড গাইডেন্স পারকিউটিনাস ড্রেন করে দেওয়া যায়, এটার জন্য ল্যাপারটমির কোনো প্রয়োজন নাই। সুতরাং আগে পারকিউটিনাস আল্ট্রাসাউন্ড গাইডেন্সে পারকিউটিনাস গলব্লাডার ড্রেন করে দিলে জাস্ট পিকটেল ক্যাথেটার দিয়ে ড্রেন হয়ে গেল, ইনফেকশন আমার সাবসাইড হয়ে গেল, পেশেন্টের জেনারেল কন্ডিশন ইমিডিয়েটলি ইমপ্রুভ করে যাবে। দেন ইউ গো ফর দ্য ERCP, and if ERCP failed, then no need of open surgery. Nowadays we are doing repeatedly, frequently done laparoscopic choledocholiectomy. No need for open surgery nowadays.
Thank you sir.
থ্যাংক ইউ স্যার। আমরা আরো নেক্সট কিছু কোশ্চেনে স্যার যেতে যাচ্ছি। যে আরেকটা খুব কোশ্চেন আসলে অডিয়েন্সের থেকে স্যার এসেছে, যে খুব কমনলি আমরা যারা সার্জনরা ফেস করি যে আফটার কোলিসিস্টেক্টমি, ল্যাপারোস্কোপিক কোলিসিস্টেক্টমি, অনেকেরই কোশ্চেন থাকে যে স্যার দেখা যায় যে ফার্স্ট ফিউ পোস্ট অপারেটিভ ডেতে 300 বা 400 ml বাইল আসতে থাকে। সেক্ষেত্রে আমাদের ফার্দার ম্যানেজমেন্টটা কি হতে পারে?
যদি ড্রেনের দিকে বাইল আসে তাহলে আগে পেশেন্টের জেনারেল স্ট্যাটাস করতে হবে। পেশেন্টের জেনারেল স্ট্যাটাসটা কি অবস্থায় আছে। যদি দেখা যায় পেশেন্ট টক্সিক না থাকে তাহলে আমাকে ড্রেনটা অবজার্ভ করতে হবে, পরিমাণটা বাড়তেছে না কমতেছে না স্ট্যাটিক আছে। দেন ফার্দার ইনভেস্টিগেশন করে আগাইতে হবে। এর আগে প্রিভিয়াসলি যদি অপারেশন হয়, যে অপারেশন হয়েছে, ইফ ইট ইজ ল্যাপারোস্কোপি 1, ইফ দেয়ার ইজ এ ভিডিও প্রেজেন্ট, the surgeon must evaluate it to look the previous operative procedures. If you evaluate the videos, then you can easily recapitulate, is there any wrong or not? Then you can easily diagnose and treat accordingly. Subsequent investigation you can do and diagnosis properly better. If there is no video is available there, the primary surgeon is not there, then you evaluate by doing some other investigation like MRCP, and easily can to some extent delineate the biliary tree. Is there any biliary tract injury or not? It can diagnose. If it is inconclusive, then subsequently go for the ERCP and identify where the pathology is. Is there any clipping? Is there any fistula formations? Then evaluate it and do accordingly. The patient is referred to the hepatobiliary surgeons and do and bypass surgery subsequently. This is the I think. Firoz Kader sir, add করবেন কিনা?
No, this is perfectly all right. আমরা যে 300 ml 400 ml বাইল চলে আসছে on the first second post operative day, সাথে সাথে আমাদের হিরোইক কিছু করার is never advised. Amra prothome will have to assess the general condition of the patient, and as has been said by Professor Shaiek Aziz, amra ekটু evaluate korbo what the surgeon has really done. Kono confusion kono jaygaye ache kina seta jodi detect korte pari oi line e amra investigate korbo. And as has been said, the first go for an MRCP, look for anything wrong that has taken place. If that is not possible, if you find anything further wrong, we can go for ESCP and take necessary measures. But we should not hurry too much for just doing any intervention immediately. We should take our time, as the patient's condition in most cases khub kharap থাকে না at that particular point. So we can take time and evaluate the patient, take help from other surgeons, take help from seniors, and discuss with them with the matter, and then resolve the situation. Thank you.
Thank you, sir. Next যে কোশ্চেনটা বেশ কয়েকজন করেছেন, that is gallstone disease and pregnancy. What is the principle of management of gallstone disease in a pregnant lady? এই ব্যাপারে যদি একটু স্যার আপনারা একটু আউটলাইন দিতেন তাহলে মনে হয় বেশ কয়েকজনই এই ব্যাপারে আমাদের কোশ্চেন চ্যাট বক্সে জিজ্ঞেস করতে চাইছেন, এবং আরেকজনের একটা কোশ্চেন আছে একটু স্পেসিফিক যে হোয়াট ইজ দ্য ফেট অফ সফট ক্যালকুলা ইন প্রেগনেন্সি, ডাজ ইট ডিসলভ আফটার প্রেগনেন্সি when the patient is no longer has pregnancy cholestasis, and is there any role of ursodeoxycholic acid in these cases?
So in pregnancy, my personal experience is last 20 years, I did about 20 cases of pregnancy with cholecystitis. Whenever the patient with acute calculous cholecystitis and the pregnancy is below 20 weeks or 15 weeks, in that cases, the situation is when the total count is raised subsequently. In that cases, I do surgery, and most of the cases I did laparoscopic cholecystectomy. Laparoscopic cholecystectomy can safely done if the facility is available, image system, good image systems, and energy sources. You can do it. But when the patient is not having a cholecystitis, no asymptomatic, you don't hurry to do surgery during pregnancy. After completion the surgery, delivery, and few months after, then the patient go for the elective surgery. But whenever the patient is acute emergency, acute calculous cholecystitis, in that case, my thinking is you must do it surgery if the pregnancy earlier period, when the pregnancy height is below umbilicus or umbilicus. At that cases, you can do it. And other thing is, whenever a patient is fasting long time, or in the pregnancy, there is a biliary sludge. That sludge is soft, represented as a soft calculus. So in that cases, no need of surgery at that time. After a few months, you can evaluate, do an ultrasonography, what about the fate of the sludge is. Sometimes this sludge is converted into stone formation at that time, and the patient is symptomatic. At that time, you go for surgery. Otherwise, no need of soft stone in pregnancy, do surgery. And ursodeoxycholic acid, what is the role? We don't know it because we have no data to prescribe the medication, what the fate it is. So those people who are giving the medications and follow up the patient, they can give the information that is there any particular rule about the ursodeoxycholic acid, etc. or not. Firoz sir, ki bolen?
Actually, Amra, in clinical practice, what we find, many cases of pregnancy at a routine ultrasonography, asymptomatic gallstone disease, prochur patient niye ashe. In those situations, Amra hurriedly kono kichu korar dorkar nai. We take necessary precautions so that the patient doesn't go into a state of acute cholecystitis. Amra fatty food avoid korte boli, this way, that way, amra jebhabe bibhinno ways ache segulo kore we try to take the whole pregnancy into a good situation so that the patient doesn't have an attack of acute cholecystitis, and patient smoothly delivers, and then we deal with that patient. Erkom asymptomatic thake. But patient jodi symptomatic hoye jay, nowadays the cholecystectomy, especially laparoscopic cholecystectomy, does not involve too much manipulation in the peritoneal cavity, which might lead to abortion. Sheta idaning kaliner statistics e kintu bole na je khub beshi promote kore abortion ke. Sei jonne Shaiek Aziz jeta boleche je amra first trimester এবং second trimester আমরা safely, with caution, with minimum possible handling of the tissues, we can safely do a cholecystectomy in an emergency situation. As regards to biliary sludge, যেখানে প্রেগন্যান্সিতে biliary stasis একটু হয় due to the hormonal reasons, metabolic reasons, সেই biliary sludge যদি symptomatic না থাকে, we should not go for any aggressive treatment like surgery or anything like that. So pregnancy-te gallstone disease management is always a little bit busier, and these are quite often asked in the examination. আমরা যদি পরীক্ষার কথা বলি, এগুলো কিন্তু আমরা বেশ practically আমরা পরীক্ষার মধ্যে আমরা জিজ্ঞেস করে থাকি. So you should be able to answer properly, and you must have a good reason for the option that you choose. Thank you.
Thank you, sir. আরেকটা কোশ্চেন অনেকেরই ঘুরে ফিরে এসেছে, স্যার, gallstone disease and chance of gallbladder malignancy. অনেকেরই এই ব্যাপারে জানার আগ্রহ আছে যে স্যার, অ্যাসিম্পটোমেটিক gallstone disease যার সার্জারি করা হচ্ছে না, মানে তাদেরকে কি রেগুলার স্ক্রিনিং এ আনতে হবে কিনা gallbladder malignancy জন্য? মানে what is the relationship of gallstone disease with gallbladder malignancy? Is there any screening protocol by all the patients of asymptomatic gallstone disease should be screened for gallbladder malignancy at regular interval?
Shaiek Aziz বলো আগে।
আমার পার্সোনাল অপিনিয়ন হলো, একটা গোলস্টোন যদি থাকে, এটা অপারেশন করে নিতে হবে, নট ফর দ্য ফিয়ার অফ ম্যালিগনেন্সি বাট ফর দ্য ফিয়ার অফ ইনফেকশন. What are the complications develops? Acute cholecystitis, emphysema, gallbladder, Meniere's syndrome. These are the troubleshooting, and it may hamper his daily activities of life. During exam, the patient may develop, the person may develop acute cholecystitis. So what can happen? His future become blind. For that reasons, the malignancy rate is not so high. But what the incidence? It depends upon what is the size the stone is. Whenever it is a big stone, there is more frictions, more metaplasia, there is chance of squamous cell carcinoma. So there is some people there is no metaplasia, small stones may causing malignancy. Maybe it does not indicate that 100% patient develops malignancy there. So for the fear of infection, pain, always do the surgery, better in the elective surgery do for prevention of complication of like empyema gallbladder, peritonitis, or other gangrenous gallbladder, or the Meniere's syndrome, etc. Not for the fear of malignancy. It is my opinion is.
So Firoz Kader sir, chat করবেন স্যার।
আমার ভলিউমটা একটু শুনতে পাচ্ছিলাম না, আমি একটু মানে কাউকে কি কোনো প্রশ্ন করা হয়েছে?
স্যার ওইটাই মানে শায়েক আজিজ বলেছেন, এখন আপনি কিছু স্যার যোগ করবেন কিনা ওই অ্যাসিম্পটোমেটিক gallstone disease?
কোশ্চেনটা একটু হ্যাঁ, প্রথম কথা হলো যে অ্যাসিম্পটোমেটিক gallstone,
আমি বলছি যে গলস্টোনের পেইনের ফিয়ারের জন্য আমরা, ইনফেকশনের ফিয়ার এটার জন্য আমরা সার্জারিতে যাব, ওই ম্যালিগনেন্সির ভয় না। ম্যালিগনেন্সি ইজ ভেরি মিনিমাল। আমি এই কথাটা বলছি
না। আমার কথা হলো যে অ্যাসিম্পটোমেটিক gallstone হলে আমরা পেশেন্টকে অপারেশন করব না, এই কথাটা কি আমরা কি সবসময় বলি শায়েক আজিজ?
না, আমি তো অ্যাক্সিডেন্ট পাইলে বলি আপনার সুবিধা মতো সময় করে নেবেন, মানে আপনার যে কোনো কমপ্লিকেশন
করে নেবেন, এক্স্যাক্টলি।
নট হারি।
কিন্তু তারপরেও যদি ডিফারেন্ট সিচুয়েশনস যে আছে, এল্ডারলি এজ, কোমরবিড কন্ডিশনস, বিভিন্ন কন্ডিশনসে আমরা বলি যে লাইফ এক্সপেক্টেন্সি খুব বেশি নাই, 70-75 বছর হয়ে গেছে, সো আমরা অ্যাসিম্পটোমেটিক রেখে পেশেন্টকে রেগুলার ফলো আপ করে আমরা পেশেন্টকে করতে হবে, সেখানে ক্ষেত্রে আমাদের ফলো আপ করতে হবে। আদারওয়াইজ অ্যাসিম্পটোমেটিক gallstone ডিজিজ ইন এ হেলদি পারসন, আমরা আদারওয়াইজ হেলদি পারসনকে আমরা cholecystectomy কথাই বলি, অপারেশন করে নেওয়ার কথা বলি, আমরা রেগুলার ফলো আপ করবো, and patient will carry on with the what should I say with this disease. এটা আমরা, this is not our expectation.
থ্যাংক ইউ স্যার। আরেকটা ব্যাপারেও স্যার, যদি ওইটা gallstone ডিজিজের সাথে রিলেটেড না, কিন্তু আমরা আসলে খুব কমনলি আমাদের প্র্যাকটিসে পাই বা হসপিটালে আমাদের ওয়ার্ডে আউটডোরে পাই বেসিক্যালি স্যার। এই কোশ্চেনটাও কয়েকজন করেছে স্যার। What is the actually the follow-up protocol for gallbladder polyp? What is the principle of management of gallbladder polyp? খুব গলস্টোন ডিজিজের সাথে খুব রিলেটেড, কাছাকাছি। এই ব্যাপারে স্যার কোনো আপনাদের কমেন্টস থাকলে সেটা স্যার আমাদের জন্য খুব উপকৃত হবে। প্রায় আউটডোর
গলব্লাডার পলিপ নিয়ে সবাই রুগীরা ওরিড হয়ে যায়, কারণ রুগী যখন আসে একটা পলিপ নিয়ে এসেই বলে স্যার আমার ক্যান্সার হয়ে যাবে। কিন্তু গলব্লাডার পলিপের প্রোটোকল হলো এটা 1 সেন্টিমিটার যদি সাইজ হয় সেই ক্ষেত্রে এটা হলো প্যাথোগনোমনিক হওয়ার সম্ভাবনা বেশি। বিলো 1 সেন্টিমিটার সাইজ এটা যে পট করে ম্যালিগন্যান্সি হবে এর কোনো ইনসিডেন্স নাই। মোর দেন 1 সেন্টিমিটার সাইজ এটা হইলে অবশ্যই গলব্লাডার ফেলে দিতে হবে। কিন্তু রুগীরা যখন শুনে যে আমার একটু মাংস বাড়ছে, এটা ভবিষ্যতে ক্যান্সার হতে পারে, স্টোনের আগে চাই এটা অপারেশন করে না, স্টোন দরকার না, এটা পাইলেই হয়েছে, যে আমি এটা এখনই করে নিবো স্যার, আমি দেরি করবো না। এই জন্য ফলো আপ করতে হবে যে গলব্লাডার পলিপ থাকলে যে এটা ইনক্রিজ হচ্ছে কিনা, এবং সাইজ যদি মোর দেন 1 সেন্টিমিটার দিকে মনে হয় পাওয়া যায় তাহলে বুঝতে হবে এটা করে ফেলতে হবে, ওয়েট করা যাবে না। ফিরোজ কাদের স্যার কিছু বলবেন?
আমি ইন মাই ফিলিং যে স্মল গলব্লাডার পলিপ হলেও আমি গলব্লাডার পলিপ অপারেশন করে ফেলার, কোলিসিস্টেক্টমি করে ফেলারই পক্ষপাতী। ওয়াই লিভ সামথিং অ্যাবনর্মাল?
হ্যাঁ, ফেলে দিতে হবে, এটা ঠিক আছে, কিন্তু হারিড নাই। কিন্তু 1 সেন্টিমিটার হইলে তখন তাকে
হারিড নাই, হ্যাঁ 1 সেন্টিমিটার হলে ইট হ্যাজ টু বি ডান এট দ্য আর্লিয়েস্ট পসিবল
টাইম, রাইট।
স্যার এখানে স্যার গলব্লাডার পলিপের তো স্যার সাইজটা আমরা জানি 1 সেন্টিমিটার, স্যার নাম্বারের সাথে কি কোনো রিলেশন আছে? এটা কয়েকজন জানতে চেয়েছেন যে
স্পেসিফিক নাম্বারের সাথে এইভাবে কিছু বলা নাই। যদি সিঙ্গেল হোক আর মাল্টিপল হোক, if one of the polyp is more than 1 centimeter, that may indicate that this is chance of malignancy subsequent earlier time.
জি স্যার, থ্যাংক ইউ স্যার। স্যার আরেকটা কোশ্চেন এসেছে স্যার, এটা একটু ইন্টারেস্টিংই, যে স্যার হাউ, এটা ডক্টর মেহেদি হাসান করেছেন, স্যার হাউ ক্যান উই প্রসিড ইন এ পেশেন্ট উইথ কোলিডোকোলিথিয়াসিস উইথ biliary pancreatitis and also pancreatic duct stone also?
So this is a complicated situation. That means gallstone, CBD stones, pancreatic stones. So evaluate the patient. What about the scenario is? If the patient is severe pancreatitis, in that case, don't hurry for surgery. First, you control the pancreatitis. After subsiding, then you go for ERCP and do the management of CBD stones. And pancreatic stones nowadays, there are also some centers, they do some that means which is called spyglass techniques. The stones can possible to broken, or some stones can having to possible to do ERCP, not ERCP, that is the ESWL, broken the stones, put a stand and evacuate the stones. These are the specialized centers needed. A specialist person, specialist center can manage that type of problems. But don't hurry whenever the presentation of the acute presentation of pancreatitis is present. First control it conservatively, then proceed subsequently.
Yes.
থ্যাংক ইউ স্যার। আমাদের অডিয়েন্সের স্যার আরো একটা ব্যাপারে খুব কনসার্ন, তেমন বেশ কয়েকজন কোশ্চেন করেছেন, সেটা হচ্ছে স্যার পোস্ট কোলিসিস্টেক্টমি সিনড্রোম, যেটা আমরা আসলে আমাদের ডে টু ডে প্র্যাকটিসে আউটডোরে পেয়ে থাকি। স্যার মানে কিভাবে একটা পোস্ট কোলিসিস্টেক্টমি সিনড্রোমের পেশেন্ট প্রায় আসে আমাদের গলব্লাডার সার্জারি 6 মাস বা 1 বছর পরে ব্যথা নিয়ে বা একটু ডিসপেপসিয়া নিয়ে, কিভাবে এটা স্যার একটা ভালো ম্যানেজমেন্ট আমরা দিতে পারি?
Usually initial presentations are the patient having some sorts of flatulent dyspepsia, fatty food intolerance, etc., which mimics with post-cholecystitis syndrome. But after few months, few weeks to few months, these symptoms are usually subsided. But whenever the symptoms are persist, at that time, you must do an MRCP. So you can easily evaluate what about the remnant of the cystic duct is. If it is a big stump there, stone remains there, so the presentations of the cholecystitis is again there. For that evaluation is taken after doing a good sonologist, they can give the informations, or you do an MRCP. Whenever you do an MRCP, it is clean-cut delineated what about the stump of the cystic duct is. Because most of the surgeons, they are worried about to injury to the common hepatic duct, common bile duct. For that reason, they don't go very close to the cystic common bile duct. Far away, the common bile duct, they divide it and giving remains a stump of the cystic duct. That stump may having a stones there or may not be stones there. That stump presentations is just like a post-cholecystectomy syndrome. So this is my personal opinion to do it. Firoz Kader sir, কিছু বলবেন কিনা?
No, this is also the same thing. The patient having all the symptoms of gallbladder disease for which the patient was operated, সেগুলো যদি থাকে, তাহলে আমরা তাকে post-cholecystectomy syndrome আমরা বলে থাকি. So patient must be evaluated properly. যখনই patient present করুক, must be evaluated properly. Check what is the condition. What was the surgery basically done? Was there any possibility that there was some sort of any mishappening during the surgery? সেগুলো detect করে আমাদের মনের মধ্যে কিছু একটা assumption নিয়ে we have got to go for further evaluation of ultrasonography, MRCP. These are different options that we must take care of, and then we should just see that whether there is really any sort of injury or any stricture by the if the patient presents a little later. তারপরে যদি আরো early part যদি হয়, if there is any biliary leakage which has resulted in biliary peritonitis and all these things. So according to the finding that we make for taking a good history and good examination and investigations, we have to take necessary steps. So কি আমাদের ফার্স্টে যদি আমাদের পরীক্ষার কথা যদি বলি, for examination আমরা post cholecystectomy syndrome ম্যানেজমেন্টের মতো কিছু প্রশ্ন যদি থাকে, first we have got to deal with we'll have to talk about the different causes of post cholecystectomy syndrome. সেইটাকে যদি প্রত্যেকটাকে একটা একটা করে আলাদা আলাদা করে যদি অ্যাড্রেস করা হয়, তাহলে this will be possible to have make a good understanding, good answer to the questions, and good management of the patient as well.
Thank you, sir. Shaiek Aziz স্যারের কাছে স্যার আমারও একটা কোশ্চেন আছে যেটা অডিয়েন্স থেকে এসেছে স্যার. ইজ দেয়ার এনি রোল অফ endo ultrasound in case of biliary disease?
Definitely. Nowadays, the endo ultrasounds take an upper hand. If the facility is available there, the normal ultrasonography, whenever we apply the probe over the surface, the intestinal gas is the enemy of the ultrasonography. So the image quality is not good enough. But whenever we do an endo ultrasound through endoscope, through the stomach and the duodenum, near the CBD, near the pancreatic duct, near the gallbladder, the probe is there, the image is high quality, and more perfection picture is given, more accurate diagnosis is done, and also do some therapeutic interventions with ultrasonography guidance and endo ultrasonography guidance can possible nowadays.
থ্যাংক ইউ স্যার. আসলে অনেক কোশ্চেন স্যার, আসলে আমি যতটুকু পেরেছি ওই কোশ্চেন গুলি গিয়ে স্যার মানে সাম আপ করার চেষ্টা করেছি. তো লাস্ট একটা কোশ্চেন স্যার করেছেন, আমি এটা দিয়ে আসলে শেষ করতে যাচ্ছি স্যার, কারণ অনেক রাত হয়েছে, স্যাররা অনেক ধৈর্য নিয়ে ইয়ে করেছেন. ডক্টর আনিস জানতে চেয়েছেন, হোয়াট ক্যান উই ডু ডিউরিং অ্যাক্সিডেন্টালি স্লিপেজ অফ gallbladder stone in CBD during laparoscopic cholecystectomy? Should we convert?
Yes, that answer is, it depends upon what facility is available here. If the patient in presence of me, in the same sitting, I do the laparoscopic choledochotomy and put the endoscopes through the choledochotomy and remove it out. But usually it is very difficult to identify this stone is slipped or not. The question is very critical, because how you confirm that this stone is slipped during surgery? If you do a parahepatic cholangiogram, only at that time you can possibly diagnose that this stone is slipped there. Otherwise, you don't able to identify either open or laparoscopy, this stone slips in the common bile duct or common hepatic duct. So if you do the parapartic cholangiogram, so there is some protocol. Not all the patient needs go for the parapartic cholangiogram. Whenever the common bile duct is prominent, dilated to some extent, at that cases you can do parapartic cholangiogram, either laparoscopically or open surgery. Whenever you do, then you can diagnose that there is a filling defect, there is stone there. Then you need to treatment. That treatment is possible. You do by laparoscopically if the facility is available there. Am I clear? If not available, at that time, you don't hurry. If there is no X-ray facility, don't go it. Keep it there. Then after subsequent investigation, confirm it and go for ERCP or subsequent it. ফিরোজ স্যার কিছু বলবেন কিনা?
হ্যাঁ, এখানে হচ্ছে যে প্রথম কথা হলো যে স্টোন আছে in the bile duct, but we went for a cholecystectomy due to cholelithiasis. So the stone কি slip করে গেছে না stone was existing in the bile duct? that is এই কোশ্চেনটা বেশি আমরা কনসিডার না করে যে আমরা we have done a cholecystectomy for cholelithiasis and but still during laparoscopy we have found that there is stone in the common bile duct. What to do? এখন কথা হচ্ছে যে এখন the laparoscopic surgeons, even the young surgeons, which I find that they are able to do the choledochotomy laparoscopically. অনেক জায়গায় এটা করা হচ্ছে সেন্টার্সে করে they take out the stone and get away with the problem. আর যদি দেখা যায় যে না স্টোন আছে, কিছু পেশেন্ট is not that way convinced যে আমরা ওপেন করব বা কিছু করব, then you come out, you take some time. The stone which did not cause obstructive jaundice in preoperative period, all on a sudden operation করার সাথে সাথে patient will go into complication due to stone in the common bile duct is quite unlikely. So you can wait, let the patient recover from the primary surgery of cholecystectomy and following choose a good time to do an ERCP and take out the stone.
থ্যাংক ইউ স্যার। আমরা শেষ একটা কোশ্চেন নিচ্ছি, কারণ এই কোশ্চেনটা উনি আগেও করেছিলেন, ডক্টর ARM ফয়জান। উনি জানতে চাচ্ছেন, I have a question about differentiating investigation about choledochal cyst and cholangiocarcinoma in both case CA99 is increased, and if the MRCP report is inconclusive, then what should we do? মানে ওনার কোশ্চেনটা হচ্ছে স্যার যে উনি বলতে যাচ্ছেন যে কোলিডোকাল সিস্ট এবং কলাঞ্জিওকার্সিনোমা CA99 বাড়ে, যদি এমআরসিপি ফিল্মটা ডিফারেন্সিয়েট না করতে পারে তাহলে স্যার আমরা কি করতে পারি?
সিটি স্ক্যান অবশ্যই করতে হবে। সিঙ্গেল এমআরসিপি ডাজ নট কনক্লুসিভ। Always do an CT scan subsequently and then can differentiate between the two pictures and findings. Not only the pictures, the CT scan and MRI, whenever the radiologist seen in the console, in the CT scan room, then they can easily demarcate it and coincide reports. Otherwise, by seeing the picture, the report is not correct one. So the radiologist must see in the console room. That means the CT scan room, there is a monitor there. With this monitor, they can roll it and subsequent pictures you can evaluate it. Which compare the MRCP. Then decision is making that this is a choledochal cholangiocarcinoma or a simple choledochal cyst is there. And ultrasonography also very important rules, but the sonologist must be expert one. All three give together, then give the conclusive result by a single radiologist. And one of my requests is all the students and doctors always practice to go into the CT scan room to look at the picture there. It can open your eye. Then you can easily evaluate and read the pictures. In my unit, the internee doctors, I take there and go to the radiology department and observe there the findings there. This is the pictures. This is the picture in the film. This is the picture in the monitor. They can easily demarcate it. What more thing can accurately seen in the console. So this is my request. All the students and doctors must go there, correlate with the radiologist and enrich your knowledge. Then you can clinically be a good doctors.
Thank you.
So yes, so preoperative confirmation by একটু বলে নিই, preoperative confirmation that whether it is a choledochal cyst or a cholangiocarcinoma, that has to be made. এটা করতেই হবে। এবং ওই যে good radiologist and a CT scan is an integral component for doing that. Thank you. Sami.
থ্যাংক ইউ প্রফেসর শাইক আজিজ চৌধুরী স্যারকে আসলে খুবই চমৎকার এবং অনবদ্য সেশন নিলেন। রাত 10টা থেকে শুরু করে 11:30 এখনো কোশ্চেন আসছে আমাদের কাছে। আসলে আমি যদি চাই মানে তাহলে আরো অনেক
মাঝখানে আমি আরেকটা পয়েন্ট একটু ক্লিয়ার করে দিই, আমার ডেসক্রিপশনে ছিল না। এই গলস্টোন পেনক্রিয়াটাইটিস নিয়ে আমরা খুব বিপদে আছি। গলস্টোন পেনক্রিয়াটাইটিস যখনই একটা পেশেন্টের ভর্তি হয়, পেইন আছে, আমরা রুটিনলি করে কি দিয়ে দেই লাইপেজ টেস্ট, সেরাম লাইপেজ করো, রুটিন প্র্যাকটিস। একিউট কেস ডায়াগনোসিস করি আমরা অ্যামাইলেজ দিই, নট দ্য লাইপেজ। কিন্তু লাইপেজ যখনই এটা বেশি দেখা যায় তখনই সবাই ওয়ারিড অ্যাবাউট এটার আর বডিতে হাত দেওয়া যাবে না। কিন্তু না, পেশেন্টের ক্লিনিক্যাল সিচুয়েশন স্ট্যাটাস, অ্যাবডোমেনটা পালপেট করে টেকিকার্ডিয়া আছে কিনা, টোটাল কাউন্ট বেশি কিনা ইভালুয়েট করে দেন ইউ ক্যান ডিসাইড দি গলস্টোন ইন দ্য সেম সিটিং ইউ মাস্ট ডু ইট, ইউ মে ডু ইট, ইউ মাস্ট ডু ইট। So my earnest request is don't treat the lipase, treat the patient, because that lipase is a costly investigations and haphazardly doing it and it causing a false conclusions to the patient. The patient is suffering more. Earlier treatment is the best one. So it is my opinion, my observations. Thank you.